medication treatment has saved lives, and certainly there's a place for it in treatments of many psychiatric disorders. But I think that the diagnostic categories have been influenced by that for sure, and in psychiatric treatment, many of the psychiatry residency programs no longer offer courses in psychotherapy. So some people have called it the medicalization of psychiatry. And so that certainly is an issue. Now, one area where there's been a lot of discussion is about looking at the distinctions between normal bereavement, for instance, and then major depression. And very clearly, the majority of people that have significant losses, this may be the most painful time in their entire life. The magnitude of suffering is enormous, and yet it's been considered that most of the time that this is part of having to walk through this time of loss. That a lot of the symptoms, you might say, are part of normal mourning process and grief. And is this psychopathology? Well, most of the experts would agree that a significant minority of people that that have a loss in their life, a personal loss in their life, will start off with a grief reaction, but then it becomes complicated, to use DSM language, or it devolves into more serious clinical depression. And this is the boundary between normal, albeit very painful, bereavement and clinical depression is a little bit blurry. This has led to there being a number of studies in the last few years where they've used psychiatric medications to treat what ordinarily would be seen as normal grief reactions. And some people say this is not a good idea because it may interfere with the natural process of grieving. At the same time, some of the studies have shown that the patients actually function better, not all of them obviously, but in group studies, some of them function better when they're taking antidepressants. And I would also say that one of the big changes that's happening that I think is going to ultimately have some influence on this is that psychiatry is a specialty that is headed for extinction. And that may sound like a really strong comment, but in the last 15 years, the number of medical students choosing psychiatry as a specialty has been cut in half. People are not choosing that as a specialty, and so I think that it remains to be seen whether or not the medicalization part of this being driven by biological models and medical model and so forth, is going to continue to be as significant as it has been in the past.
When people get upset about the removal of the bereavement exclusion, they say, well, these primary care physicians who only have an average of 7 minutes in their visit, how are they going to know whether we should just be kind of working this through with perhaps talk therapy, or should we be prescribing an antidepressant? And when people are protesting, as many of them are, DSM-5, I say, there's a time when it's appropriate to protest, but once it's out, it's no longer appropriate to protest. What we need to do is develop guidelines. We need to mitigate those things that we feel are problematic. So I guess what I'm asking you in a way is would it be possible for a working group to develop guidelines to help primary care physicians make a determination like, yes, this is one of the cases where an antidepressant would help someone stabilize a bit, or no, we don't really need it in this case? How would you approach mitigating what people are worried about as a possible dangerous tendency?
Okay, that's a great question. It may sound like I'm using too many baseball metaphors, but the diagnosis a la DSM is like getting to first base. But beyond that, if you look at something like depression or complicated bereavement, it's enormously complex. And one of my professors in grad school said, remember, dogs can have fleas and ticks. And so there are people that have grief, but it's complicated by things like substance abuse, or they have a medical condition like thyroid disease, for instance, that contributes to depression, or they're taking a prescription drug that may intensify depressive symptoms. And so if you just say a treatment like medicine versus no medicine based on the diagnosis, that doesn't come anywhere close to really giving good guidelines when you're dealing with the kind of complexity that you see with the human psychological condition. I think it is possible to help design some approaches to help primary care doctors do more than just the is this drug or no drug kind of situation. And yet there's a big challenge, and that is what you mentioned, very, very small amounts of time to do adequate evaluation. And the biggest problem is that if they do start treatment, whether it's a medication or they suggest a referral to psychotherapy, there's hardly ever any follow-up. So I think that DSM is a starting point, but as you are strongly suggesting, I think, is that it's really going to be important for us as mental health providers, but also just looking at this from a society-wide basis. There are so many people out there that are suffering and not getting appropriate treatment. To recommend ways to go beyond just a simple diagnosis and look at the critical factors that go into decision-making about what kinds of treatment are necessary. And, it's one thing to say, is this the kind of problem that psychotherapy is best suited for or medication? But there's a lot more beyond that. There's things like, for instance, enhancing the quality of sleep and the amount of exercise and even some dietary approaches that in any kind of thoughtful kind of approach to treatment need to be taken into consideration. And so one place to aim this is at primary care, because that's where a lot, if not most people, go when they encounter some very significant emotional problems. People are disinclined to see psychologists and therapists oftentimes for various understandable reasons, and psychiatrists are hard to get in to see and few and far between. So I think a real high-yield place to go would be to put together some practice guidelines to help primary care doctors and nurses, people in that field, be better at teasing out the individual issues going on with each individual person, instead of there being like sort of a cookie-cutter approach where people are looked at in very simplistic ways and then sent on their way.